Assalamu alaikum warahmatullahi wabarakatuh. Welcome back to the channel of Standard Medical Notes and Lecture. So let's finish this topic of diabetic neuropathy. So what should be the diagnostic approach of this a patient who is presenting with neurological symptoms? So diagnostic approach, so it should be like this. The diagnostic workup is designed to identify nerve dysfunction, determine if the patient has loss of protective sensation, and exclude non-diabetic etiologies. So these are the two goals in the diagnostic approach. We should exclude non-diabetic etiologies of the neuropathy, and if it is there, meaning DSPN is there, then we should see whether the patient has LOPS or not. So patient with diabetes presenting with distal neuropathic symptoms, important to remember. So 4-step approach. Number 1, take the history, assess symptom characteristics, onset, duration and progression, because the onset is usually gradual and there will be a long history of diabetes mellitus or uncontrolled or poorly controlled diabetes mellitus. If it is abrupt onset and more of motor symptoms than sensory, then more likely it is not due to diabetes. What is the type of pain, whether it is burning, tingling, numbness? So these are all neuropathic type of pain. What are the aggravating and relieving factors? So in DSPN it is worse at night and it is relieved by walking. So it is opposite to the vascular claudication, where the patient feels good when he rests and pain starts if he walks. So that is a very important factor. So see whether any risk factors are there, or whether the patient uses alcoholics, because there is alcoholic neuropathy also. So nutritional status, whether the patient is well nourished or not. Medication history, patient taking metformin have deficiency of B12, so that is very important. Okay, alcoholic history and metformin history and nutritional history, because this deficiency of key nutrients will lead to neuropathy. Okay, so after taking history, what's the onset, what is the duration, how is the progression, what was the duration of diabetes mellitus? So how is the pain, means what is the type of the pain, burning or claudication type of pain, when it aggravates, when it relieves, and what are the medications which the patient is taking, whether the patient is alcoholic or not. After taking this history, then we will meet to some basic laboratory tests to exclude treatable non-diabetic causes. So we'll do B12, we'll do thyroid function test, renal function test, because uremic neuropathy can also occur. So medication review to see whether there is metformin, and CBC, fasting glucose and HbA1c. So CBC, fasting glucose and HbA1c. Why? Because this will tell us the diabetic status of the patient, whether it is good controlled or not. Second, we will exclude LOPS. Okay, LOPS meaning loss of protective sensation, by two things: 10-gram monofilament test and 120 Hz tuning fork. Okay, so by this 10-gram monofilament test, we will measure the sensation at 10 sites on each foot. If the sensation is perceived less than or equal to 8 sites, then the patient is at high risk of your diabetic foot, okay, infection. We will test vibrations perception at grade 2 or ankle by this 128 Hz tuning fork. Okay, so pain sensation is lost, vibration sensation is lost, and so that, keeping that in mind, we are doing this 10-gram monofilament and tuning fork test. Assess pinprick, temperature, proprioception as needed. Okay, deep tendon reflex. So first the ankle reflex will go, then the knee reflex will go. So what is the presentation of the patient? Okay, so I think this should come first. Actually, this should come first. Okay, in the history only this should come. So if the patient is having typical presentation like symmetric and gradual, sensory more than motor, then it is probably due to DSPN. If the patient has atypical presentation, like if it is asymmetric, rapid, motor more than sensory, consider alternative diagnosis like CRDP, radiculopathy, entrapment neuropathy, vascular neuropathy or neoplasm. Okay, further evaluation needs EMG, NCS, imaging, autoimmune markers. And then you, after diagnosing the etiology, you will you will initiate the management. Confirm the diagnosis of DSPN based on typical pattern and LOPS. These two things, typical pattern and LOPS. Address glycemic control or modify risk factors. Start symptomatic treatment for neuropathic pain. Educate on food care and regular follow-up. So always the key points are always rule out treatable causes. LOPS assessment is essential for risk stratification. Early diagnosis prevents ulcers and amputations. Okay, we have, this is the diagnostic approach for DSPN. We should take history, and in history only we should remember this thing, this whether the presentation is typical or atypical. So this is a diagnostic approach for distal symmetric polyneuropathy. Okay, distal neuropathy, where the two goals are to exclude the non-diabetic etiologies and to see whether LOPS are present. If LOPS are present, then we'll take measures. So these are the things. Baseline tests we will do. Okay, so that's about the approach. Now coming to diagnostic steps in diabetic neuropathy. So first we will do 10 gram monofilament test. Okay, technique: apply the monofilament perpendicularly to 4 plantar sites on each foot, avoiding calluses until it buckles, held for 1.5 seconds. So Davidson says 10 sites. Remember, Davidson says 10 sites, and if patient doesn't feel at less than 8 sites, then the patient is at high risk of amputation, or you can say LOPS is present. The single most cost effective and validated tool to diagnose LOPS. Okay, inability to pursue the monofilament confirms LOPS, placing the patient at high risk for foot ulceration. If the LOPS is confirmed, patient is at high risk of foot ulceration. Tuning fork test already discussed. If it is abnormal, patient does not feel vibration but examiner still feels it. So again, we should exclude vascular claudication. So we should palpate the pedal pulse, mainly the posterior tibial artery and the dorsalis pedis artery, and we should confirm by ankle brachial index. So if the ankle brachial index is less than 0.9, then it is peripheral arterial disease. If it is between 0.9 to 1.3, then it is normal. If it is more than 1.3, then it signifies calcified vessels. So it is a false elevation of ABI, which is mainly seen in elderly individuals. In that case, we should go for angiography, CT angiography, or MRA, magnetic resonance angiography, or we can also do toe brachial index. One more thing, toe brachial index also we can perform in these patients who are having ABI more than 1.3, mainly in elderly patients. So these are the things. Okay, now, so that was about somatic sensations. Coming to autonomic assessment, so cardiovascular autonomic reflex tests. So there is one thing known as heart rate deep breathing response, where you calculate RR interval variation during deep breathing. So it is abnormal if maximum to minimum heart rate difference is less than or equal to 10 beats per minute, signifying vagal impairment. Or you can perform Valsalva maneuvre. So ratio of longest to shortest RR interval is abnormal if it is less than 1.2. I think this is the most important and easy method we can do, where orthostatic blood pressure measurement, a fall in SBP of more than 20 or DBP of more than 10 mg within 30 seconds of standing up from a supine position, that says that there is autonomic dysfunction. So gastrointestinal evaluation. So what we are doing, we are seeing whether the patient is having gastroparesis or not. So for that, first you should exclude any ulcer or gastric outlet obstruction by doing endoscopy. If it is not there, then we will perform a test known as radionuclide gastric emptying study to see whether the patient is having gastroparesis or not. Okay, but one thing we should remember, that we should not perform this test when if the patient has more than 270 milligram per deciliter, because their acute severe hyperglycemia itself causes gastroparesis because meaning, okay, the patient will feel early satiety, that is gastroparesis. The patient will feel early satiety, abdominal bloating. So, and some patients will also have constipation, diarrhea, sometime constipation, sometime diarrhea. So these all things, resting tachycardia and orthostatic hypotension, all these things signify this your autonomic nervous system failure. So when you should do advanced investigations, so EMG and nerve conduction studies should be done when there is atypical presentation. Okay, what is that? Motor more than sensitive shifts, rapid onset, asymmetric. Okay, suspect CIDP. Foot MRI and indium 111 labeled. When you perform this, when you are not able to differentiate between Charcot arthropathy and osteomyelitis. So to differentiate Charcot's neuroarthropathy from osteomyelitis, because in Charcot arthropathy also you have fractures, okay, and bony fusion. So and there is swelling, there is erythema, all those things are there. So to differentiate that from osteomyelitis, what you do foot MRI, okay. So that's about the advanced imaging investigations, okay. Now coming to the management strategy for diabetic neuropathy. So it depends upon the presentation of the patient. If the patient presents with painful neuropathic flares, meaning just he is having pain, DSPN you can say, okay, distal symmetric polyneuropathy, so we should initiate non-opioid pain pharmacotherapy. Should not use opioids like morphine, oxycodone, tramadol, tapentadol are not recommended as first or second line agents due to the high risk of addiction, tolerance, and lack of long term efficacy. So we will use neuropathic drugs like duloxetine, pregabalin and gabapentin, tricyclic antidepressants, and finally topical lidocaine 5%. So these four groups of drugs we use: duloxetine, gabapentinoids, TCAs, and topical lidocaine. Suppose the patient presents with acute Charcot neuroarthropathy. So the goal is complete immobilization and absolute offloading using a total contact plaster cast or an irremovable air cast boot. This is typically required for 3 to 6 months until the acute inflammatory phase resolves. What is that? Skin temperature of the affected foot is within 1 to 2 degrees Celsius of the contralateral foot. Okay. So either we can use a total contact plaster for 3 to 6 months or a irremovable air cast boot. Monitor for 3 to 6 months. If when the skin temperature difference between the two foots is less than 1 to 2 degrees Celsius, then we can remove it. Okay. So what is our main aim? Why you are putting plaster? To prevent deformities. Okay, because deformities will deformities, what they will do, they will help in the development of calluses, and calluses in turn they will cause microorganisms entry. They become portal of entry for the microorganisms, and that will cause diabetic foot. And osteomyelitis can also occur. They are prone for development of ulcers. So deformities, to prevent the deformities, that's our goal if the patient is having Charcot neuroarthropathy. Now if the patient presents with a diabetic foot infection, for example like ulcer, then perform urgent surgical debridement of necrotic tissue and surrounding callus and obtain deep tissue cultures. Avoid superficial swabs which only reveal colonizing flora. Start broad spectrum empiric IV antibiotics, example piperacillin tazobactam or ampicillin sulbactam. Add vancomycin if there is high local prevalence, more than 10% or known exposure to MRSA. So urgent surgical debridement, deep tissue culture, then broad spectrum antibiotics, then after culture narrow spectrum antibiotics. Okay, vancomycin should be added when the MRSA prevalence is more than 10% or there is known exposure to MRSA. Chronic management. How do you manage the patient who is having neuropathy in the long term? So first measure is glycemic control. So control the diabetes in both type 1 diabetes as well as type 2 diabetes. What should be the target? HbA1c should be less than 7% in most patients. Avoid aggressive targets. Example, HbA1c less than 6% in older frail patients or those with multiple cardiovascular comorbidities due to risk of severe hypoglycemic falls. Then proactive foot care and offloading. So patients who are having deformities, so in them educate patients with LOPS, meaning who have loss of protective sensation, to inspect their feet daily and wear seamless socks with the seams turned inside out. Prescribe custom molded therapeutic footwear with a broad square toe box and cushioned insoles for patients with bony deformities or a history of ulceration. So footwear also, okay, socks and footwear. Then the patient who is an autonomic symptom management. Okay, so orthostatic, elevate the head of the patient who is having orthostatic hypertension, elevate the head of the bed to 30 degrees, utilize compression garments and ensure adequate fluid and salt intake. Okay, this is head up to 30 degrees, compression garments, okay, and fluid and salt intake. Avoid vasodilators and tricyclic antidepressants because they will exacerbate orthostatic hypertension. Our goal is to relieve the symptoms and prevent complications and maintain quality of life in these patients. Common clinical pitfalls to avoid. The cellulitis misdiagnosis, misdiagnosing an acute Charcot foot as cellulitis or osteomyelitis. So these three should be differentiated. And treating with antibiotics alone without offloading. So this is a pitfall. Walking on an acute Charcot foot causes permanent skeletal collapse, rocker bottom foot deformity. So avoid opioids in patients who are having neuropathic pain. Okay, and relying on a falsely normal ABI. Assuming a normal ABI rules out peripheral artery disease. So this is okay. But if the ABI is more than 1.3, so you should think you should go for either toe brachial index or CT angiography. You can do, or nowadays you can do Doppler ultrasonography also. Okay, that's about the management. So management of painful neuropathy, management of Charcot arthropathy, management of diabetic foot, and control glucose, wear a customized footwear and socks for autonomic in orthostatic hypertension, elevate head end, and wear compression stockings. Now these are the drugs which are used. So gabapentinoids, number 1, includes pregabalin and gabapentin. SNRIs, in that duloxetine and venlafaxine. Tricyclic antidepressant, in that amitriptyline and desipramine. Sodium channel blockers like locasamide and carbamazepine. Okay, that's about in painful neuropathy. For gastroparesis, you use prokinetics. Number 1 is prucalopride, and then metoclopramide, domperidone, erythromycin. Third is cardiovascular autonomic hypotension, that is orthostatic hypertension. So there you can use fludrocortisone and midodrine. Erectile dysfunction, sildenafil can be used. Topical agents like capsaicin can be used for painful neuropathies. Nutritional support should be given for the patients who are having this kind of things. Okay, so these are the pregabalin the starting dose is 50 mg, maximum it can be up to 600 mg per day, and increase the dose to 300 mg per day in 1 week. Contraindication, hypersensitivity reaction. Side effects are somnolence, dizziness, peripheral edema, weight gain, and blurred vision. So one important thing is FDA approved absorption with more than 90% bioavailability, 6 times higher binding affinity than gabapentin. So it is more effective than gabapentin, and requires strict renal adjustment. That is important. Gabapentin start at 300 mg at bedtime, and the target dose is 300, meaning the therapeutic dose is 300 mg TID. Maximum you can go up to 3600. So same side effects: sedation, ataxia, confusion, dizziness, peripheral edema, GI upset. Okay, so it has an off-label for DSPN. It is a cheaper alternative. Follows saturable. The bioavailability is less compared to the your pregabalin, and this also requires renal adjustment. Duloxetine start at 6 mg, give to up to 1. You can go up to 120 mg. So hepatic impairment and renal impaired, you should decrease the dose. Okay, do not use if the patient is having G4 category of CKD. Side effects are nausea, dry mouth, somnolence, anorexia, constipation, hyperhidrosis. All these are side effects. So this is FDA approved first line agent, highly effective in patients with comorbid depression and anxiety. So pregabalin and duloxetine, they are highly used for diabetic neuropathy. Venlafaxine, starting dose 75, maximum up to 225 once daily. So here the side effect is mainly uncontrolled hypertension. Okay, this is a contraindication. Uncontrolled hypertension. Side effects: this cause nausea, somnolence. So it has a effect on heart. BP is elevated, and there will be ECG changes. So off-label use may be added to gabapentin for a synergistic response in refractory cases. So you can use this venlafaxine in refractory cases. See the patient's heart rate, ECG first, and blood pressure first, then you decide. Amitriptyline, tricyclic. So start at 10, you can go and therapeutic to 25 mg can be dosed, and you can go up to 75 to 150 mg per day. But the contraindications, because it causes QT prolongation, cardiac arrhythmias, post-MI, it can cause acute, in patients with acute angle glaucoma, you can't use this. So the side effects are usually anticholinergic side effects. Okay, this is effective, but this is very poorly tolerated. Avoid in elderly aged patients more than 60 years of age due to anticholinergic and fall risk. Fall, why? Because there is orthostatic hypotension. Okay, because of amitriptyline. Desipramine 10 again 725, you can give up to 100 to 150. Contraindication again same cardiac conduction defects, anticholinergic side effects similar to amitriptyline. This is preferred TCA in older adults. Okay, this is preferred tricycle antidepressant. Desipramine is preferred, not amitriptyline, because your anticholinergic effects are less and lower sedation profile. That is, desipramine is preferred over amitriptyline. Okay. Bedtime again same. Okay. So these are sodium channel glucosamide. These are usually used for epilepsy purpose, but not used now. Okay, you can read this thing. So Prucalopride is given 2 mg orally. The patient who is having abdominal bloating, okay, or constipation, or you can say early satiety, all those patients. So this is gastroparesis. You can give this is 2 mg orally once daily. Contraindications are intestinal perforation, obstruction, so toxic megacolon, side effects, headache, nausea, diarrhea, abdominal pain, and flatulence. Okay, safe cardiovascular profile. So prucalopride dose should be reduced to 1 mg when the patient is in G4, similar to duloxetine and venlafaxine, where there is dose in pregabalin also. Pregabalin, duloxetine, venlafaxine, amitriptyline, all these agents require dose adjustment in renal failure patient, because renal failure is CKD is usually associated in these patients. So metoclopramide 5 to 10 mg orally 3 times daily. Okay, so these are the side effect. Okay, one important drawback is tardive dyskinesia or extrapyramidal syndrome. Okay, alternative domperidone is metoclopramide is domperidone, which is given 10 mg orally 3 times daily. Okay, so because it is a peripheral dopamine antagonist, so it has fewer extrapyramidal side effects, but it causes QT prolongation. Erythromycin not used. Okay, fludrocortisone you can give 0.0 mg orally daily and can titrate up to 1 mg per day. Contraindications are heart failure and patient with severe hypokalemia. Okay, so it causes fluid retention, hypokalemia, hypomagnesemia, worsening supine hypertension. Okay, promotes renal sodium retention to expand plasma volume. Monitor blood pressure and serum potassium because there will be hypokalemia. Midodrine, other drug which is used for orthostatic hypertension, 2.5 to 10 mg is the dose, orally 3 times daily, 0.1 to 1, 2.5 to 10. Okay. So avoid dosing within 4 hours of bedtime to prevent supine hypertension. Midodrine causes supine hypertension, as well as fludrocortisone also causes supine hypertension. So we should supine hypertension, they cause hypertension. Similarly, venlafaxine also causes hypertension. Okay, and cardiac side effects, QT prolongation. Sildenafil 50 to 100 mg orally 1 hour before intercourse. Okay, concomitant use of nitrates, so this is contraindicated because it is a phosphodiesterase inhibitor, so it can cause cardiovascular collapse in these patients who are taking nitrates. Patients who are having concomitant cardiovascular disease and they are taking nitrates, phosphodiesterase inhibitors are contraindicated in that. They can have some other for impotency, they can have some other measures like injection prostaglandins locally, all like that. Okay, capsaicin, okay, already you know, it depletes substance P from transmitting C fibers, and burning sensation may transiently worsen before pain relief occurs. Okay, that's about the drugs. Just remember the names. Okay, prucalopride is a very important drug for gastroparesis, and fludrocortisone, this can cause hypertension with hypokalemia, supine hypertension. Sildenafil very commonly used for erectile dysfunction, but should not be used in patients with nitrates, taking nitrates. So pregabalin, important drug, duloxetine. Okay, and instead of using a single drug with high dose, you can combine multiple drugs with low doses. So you are tackling the thing with multiple pathways, and you are simultaneously you are reducing the side effects of each drug. Venlafaxine causes hypertension, elevated blood pressure, ECG changes. So when you use venlafaxine in combination therapy for refractory cases, desipramine is preferred for elderly, and amitriptyline is not preferred in elderly. Okay, that's about the pharmacological agents. Now coming to special situations. In renal impairment, there is gabapentinoid accumulation, so you should reduce the dosage. Pregabalin, so if the eGFR is 30 to 60, so meaning G3 stage, patient is in G3 stage, so standard dose is 150 to 300 mg. So reduce the dose to 75 to 150 mg per day. Okay, that is the maximum dose. Now if the patient goes to C5, G5, then restrict the dose to 25 to 75 mg once daily, with supplemental dose of 75 to 150 mg post stimulus. Better to avoid this drug because it accumulates fluid in the body. Okay, so that's why better to avoid in G5 stage. Okay, you can reduce the dose in G3 stage. Gabapentin similarly, the reduce the maximum dose to 900 mg. Okay, if the patient is in G4, then reduce to 600 mg in 1 to 2 divided doses, and if the patient is G5, then restrict the dose to 300 mg once daily. Okay. Avoid utilizing duloxetine entirely in patients with severe renal impairment in G4 due to the accumulation of active metabolites, which can cause severe nausea, gastrointestinal toxicity, and somnolence. So G4 you should avoid this one, but you can use in all stages this carbamazepines by reducing the doses. Okay, reducing the doses you can use. Okay, easy to use is gabapentin because the dosage is easy, or we can also use this pregabalin also. Proculopride, so less in G4 we should reduce the dose to 1 mg. Okay, what do you do in pregnancy? Preferred glycemic management, insulin is the gold standard. Metformin crosses the placenta and has uncertain long-term. Glyburide is not recommended due to increased risk of neonatal hypoglycemia. So insulin should be used. Cardiovascular protection, immediately discontinue ACE inhibitors and statins upon confirmation of pregnancy due to high risk of fetal renal dysgenesis and teratogenicity. Neuropathic pain pharmacotherapy, anticonvulsants and gabapentinoids are considered last line options during pregnancy due to limited safety data. So valproic acid should not be used in pregnant ladies. Okay, use non-pharmacological therapies like topical agents or low dose preferred options in patients who are pregnant. So you can use low dose tricyclic antidepressants like amitriptyline. If gabapentinoids are unavoidable, you want to use, then prefer gabapentin over pregabalin. In pregnancy, and amitriptyline in case of TCS low dose, and gabapentin is preferred over pregabalin if you want to use. Carbamazepine co-prescription. If carbamazepine is used, co-prescribe high dose folic acid B9 until term to reduce the risk of neural tube defects. One point to remember is your insulin neuritis, acute treatment induced neuropathy. What is that? This is triggered by rapid therapeutic reduction in blood glucose levels, typically following the initiation of intensive insulin therapy or starting an insulin pump. It is similarly to your rapid reduction of blood pressure causes ischemic things, no? And similarly, rapid reduction of glucose causes exacerbation of your retinopathy, no? Similarly, rapid reduction of blood glucose causes exacerbation of neuropathy. That is nothing but insulin neuritis. That's all. Okay. So there is sudden onset of severe symmetrical burning pain and dysesthesia in the distal extremities. So it is a reversible and self-limiting thing, typically resolving within weeks to months, without long-term sequelae if gradual glycemic control is maintained. Supportive pain management is the key therapy. You should not decrease the dose of but if the patient is having your diabetic retinopathy, then you should gradually reduce the HbA1c. But if there is no retinopathy, then neuropathy, insulin neuritis or acute treatment induced neuropathy, you should not reduce the dose, just treat it symptomatically. Okay. So the special situations are in renal patients, because these patients already have diabetic kidney disease also and diabetic eye disease also. Pregnancy patients, pregnancy you can't use, okay, except TCS and gabapentin, last option. So last revision slide. So diagnosis of diabetic neuropathy is a diagnosis of exclusion, chronic hyperglycemia induced somatic and or autonomic peripheral nerve injury, loss of protective sensation, asymptomatic distal sensory loss. So LOPS, you can think it as microalbuminuria, microalbuminuria of nerves. What is LOPS? LOPS is microalbuminuria of nerves. What is microalbuminuria? Microalbuminuria is nothing but patient will be asymptomatic, but there will be diabetic kidney disease. Similarly, patient will not have any symptoms of neuropathy, but LOPS will detect that. So LOPS is equivalent to the microalbuminuria of diabetic kidney disease. So LOPS is nothing but microalbuminuria, or you can say a rule out test for neuropathy. So LOPS, very important. So this is the pathophysiology. Management. So distal symmetric symptom the patient is having, you will do 10 gram molybdenum and 128 hertz, and you will see symmetric symptoms or asymmetric symptoms. If the patient has asymmetric atypical symptoms, exclude other causes like B12, hypothyroidism, CIDP, radiculopathy due to spine disc, peripheral artery disease, and nerve entrapment. All these things, no, they will be asymmetric, but DSPN, it will be symmetric. That you should remember. So B12 deficiency, hypothyroidism, radiculopathy or CIDP, peripheral artery disease, and nerve entrapment syndromes. Even nerve entrapment syndromes, they can. So you should think of some other disorders also. If these are excluded, then you can think it can be diabetic amyotrophy like thing, or mononeuropathy, it can be, okay, like that. So top 3 red flag pitfalls: cellulitis misdiagnosis as Charcot arthropathy and Charcot foot, you will misdiagnose. Okay, opioid you should never prescribe. False ABI reassurance. Okay, relying on a normal ABI in patients with calcified non-compressible vessels. Utilize low pressure CTA MRI instead. One-liners. Type 1 diabetes mellitus tight glycemic control reduces neuropathy risk by 70%. Inability to pursue 10 gram molybdenum indicates LOPS and predicts ulcers. Restless burning pain that is worse at night and relieved by walking is classically neuropathic, not ischemic claudication. Fetal exposure to valproate carries 10% risk of congenital malformations. Rapid correction of long-standing hypoglycemia can trigger acute transient induced neuropathy. So this is an example practical case scenario of diabetes DSPN patient with DSPNC. Here is a patient named Mr. Ahmad Khan, age 50 years, sex male, school teacher. So burning sensation in both feet for 8 months, tingling and numbness for 1 year, electric shock like pain, worse at night, difficulty walking barefoot, poor sleep due to the pain. Diabetes history, type 2 diabetes for 13 years, poor glycemic control, last HbA1c 9.4%, irregular medications, metformin and glimepiride. So we should specifically ask for this somatic and autonomic symptoms. So like autonomic dizziness, constipation, erectile dysfunction, somatic burning, tingling, numbness, selective shock, loss of balance, autonomic symptoms. So these should ask. Risk factors: diabetes for more than 10 years, hypertension, dyslipidemia, obesity, smoking, sedentary lifestyle. So vitals, you see BP is not controlled, pulse is okay, BMI, his weight is more, 10 gram when we have done, and it is abnormal at multiple sites. 120 hertz, vibration sensation is reduced, pinprick is reduced, temperature is reduced, proprioception is slightly impaired. Ankle jerks absent bilaterally, very important. Knee jerks are reduced, power is good, there is no motor like thing. Mild intrinsic foot muscle wasting, clawing of toes is there, that means the patient is also having Charcot's arthropathy. Dry cracked skin, callus or metatarsal head, no active ulcer, peripheral pulses are palpable, that means okay, it is probably the patient is not in peripheral artery disease. Okay, differential diagnosis: it can be B12 deficiency, it can be alcohol due to hypothyroidism, CKD, cervical myelopathy, lumbar radiculopathy, okay, drug induced neuropathy. So you should exclude all these causes. Investigations: HbA1c, CBC, B12, TSH is normal, P12 is normal, creatinine, EGFR is also normal, but urine albumin is positive. The diabetic kidney disease is there. Lipid profile is 145, LFT is also normal. Nerve conduction study was done, so it is indicating symmetrical distal sensory motor axonal polyneuropathy. ABI is normal. So the diagnosis is DSPN, moderate severity, but there is no active ulcer. So this is the management. We will discontinue the glimepiride. We'll start the drugs like metformin, will give empagliflozin, and we will start semaglutide because the patient is overweight. Target HbA1c is less than 7%. Then for symptomatic treatment, we'll start either pregabalin, duloxetine, gabapentin, or we can use a combination therapy like pregabalin, duloxetine. We will not use opioids and long-term NSAIDs or chronic corticosteroids. So we will say the patient to inspect the food daily. Daily food inspection, moisturizer for the food for dry skin, proper diabetic footwear, never walk barefoot, daily sock change, trim nails carefully, treat callus professionally. So target blood pressure less than 130 by 80 and AC inhibitors or AC ARB should be used. Lipid management, atorvastatin 40 mg night. Lifestyle modification, weight reduction, healthy diabetic diet, exercise 150 minutes per week, balance and food, strengthening exercise, adequate sleep. Now follow up at 4 weeks, pain score is good, it is reducing. Follow up at 3 months, HbA1c is also reducing, pain again it is reduced, weight, patient has lost the weight 4 kgs, BP is also decreasing. Every visit we should inspect the food, monofilament testing should be done, footwear review, medication adherence, pain assessment. Every 3 months you should see HbA1c, and every 6 to 12 months we should have kidney function test, lipid profile, B12 in long term, comprehensive food examination. Red flags are food ulcer, rapidly progressive weakness, asymmetric neuropathy, severe autonomic dysfunction, charcoal food, hot swollen food, suspected osteomyelitis, critical limb ischemia, peripheral artery disease. So this is the outcome after 6 months. HbA1c is now 6.9%, pain score is 2 by 10, better sleep and quality of life, improved sensation stability. Okay, no foot ulcer or amputation, independent walking maintained. Pain relief does not reverse nerve damage. The primary goal is symptom control while preventing foot ulcers. Tight but gradual glycemic improvement reduces progression of neuropathy, but established neuropathy is often only partially reversible. Every patient with diabetes should undergo annual screening for DSPN, and patients with abnormal findings require ongoing foot surveillance. Patient education and daily foot care are as important as pharmacological therapy in preventing ulceration and amputation. Okay, that's all about diabetic neuropathy. Thank you.